due to an emergency, but we're incredibly lucky to have Joe Wheeler stand in. Joe is incredibly experienced. And Joe, I want to thank you for taking the time to cover this webinar. Joe has over 20 years of experience as a speech and language therapist, working with patients with communication and swallowing disorders. She is a clinical specialist at the Head and Neck Cancer at the QE in Birmingham, and she leads the surgical voice restoration service and jointly runs the SLT-led video fluoroscopy fees and swallow clinics. And her key clinical interests are in dysphagia, oncologic voice disorders, surgical voice restoration, and tracheostomy management. And with that, Joe, I welcome you to the floor. Thank you for your time.
Thank you. Right, let's see if I can get this to share. Okay,
that's perfect, Joe. Yes, that's
amazing.
Perfect. Thank you.
Brilliant. Let's just. Sorry, just 2 seconds.
Take your time because it allows us to filter everyone in, so don't worry. That looks perfect.
Great,
thank you.
It's just warming up here. It's just doing its thing.
Oh no, it's fine. It's just a webinar, so I'm not talking.
Now, unfortunately, I can't get Camilla's presenter points to presenter view's gone off, but you know, we'll gloss over that. Okay, so this is Camilla's presentation. It's not my presentation, but I'm hoping I will be able to do it some justice. So bear with me. So I'm going to present to you on speaking, swallowing, and surviving post-laryngectomy care in ENT. So the learning outcomes for this, we're thinking about swallow and surgical voice restoration. So 1, swallow rehabilitation. So I'm going to explain to you the principles of swallowing rehabilitation with and without laryngectomy. We're going to explore the instrumental assessment techniques. So we're going to recognise indications, advantages and limitations of fees and video fluoroscopy. And we're going to look at voice prosthesis. So we're going to think about differentiating types, describing their insertion, routine care and management of complications such as displacement. This is a quote from a patient that Camilla interviewed by the researcher. The patient said, "People will say, well, at least you're alive. Yes, but I want to be alive in the best way I can." So when we're thinking about these patients, we have to be thinking about their outcomes. We have to be thinking about optimising swallow, optimising speech. And as ENT registrars, that's really essential that you're thinking about people in terms of their outcomes. So if we're thinking about swallow rehabilitation, I guess let's go back to basics. So what do we think about when we think about swallow? We think about the oral phase, we think about the pharyngeal phase, we think about the esophageal phase. So when we think about how the bolus descends from one area to another, it goes from an area of high pressure, so an area of high pressure within the oral cavity, then goes to an area of low pressure within the oropharynx, and an area of even lower pressure within the hypopharynx, and then within the esophagus. But we need to enable these structures have two distinct areas. We need to be able to breathe and we need to swallow, but they share the same apparatus. Now we swallow during the expiratory phase, and then we have a pause event, the apneic phase. With the respiratory pause interrupts quiet breathing, and the lung volumes in that range are from mid to low tidal volumes. And that's dependent on the central pattern generator, which modifies the motor response following feedback from the efferent and afferent pathways. And the next, a schematic of that. So as you can see there's the sensory inputs via on the blue route, the motor inputs, outputs on the red, and that's quite a nice schematic that demonstrates that. So this is a video fluoroscopy of a swallow. play that for you now. I don't know whether you're all familiar with videothroscopies, but as you can see, the bolus transitions there from the mouth down into the oropharynx and down into the esophagus. I'll play that for you again. And you can see that the hyolaryngeal complex is rising and tilting forwards. And none of that bolus is entering the airway. When we think about swallowing, we think about how efficient is the swallow. So how well are we able to get food and drink from the lips, from the mouth, down into the esophagus? And how safe is the swallow? So how well are we able to protect the airway when we're swallowing? And often those two things are intertwined. And then you can see here, this is a picture of a patient aspirating. And that's quite a significant aspiration, not uncommon in what we see. And then these are two videos of fees. So this is a fees examination here on the left. This patient has, as you can see, got quite a lot of the bolus. It's quite diffuse. I will play it for you now. So nasogastric tube in situ. But what you can see here is coordination has become a real issue for this patient. So they're not able to coordinate the apneic phase. The vocal cords aren't coming together in a particularly coordinated way. This is a patient that's recently been extubated from her ET tube. And as you can see there, makes me wince, there's quite significant aspiration. And we think about aspiration when food, fluid or secretions enter the airway and go below the level of the vocal cords. That's aspiration. And that can be either silent, where patients don't respond, or maybe moreover if a patient coughs. And then this is the right bronchus of the patient. As you can see, some mucus plugging and some secretions, and also some yoghurt there. Okay, so thinking a little bit more about swallowing, we need to be thinking in terms of pressure differential, propulsion of the bolus and flow of the bolus. So we think about things like lubrication from the oral cavity, and we think about pressure, particularly pressure from the tongue and the tongue base. We need to be thinking about coordination, and that's coordination of breathing and swallowing. And we're thinking about the motor and sensory pathways that are involved. And what is aspiration? We've just covered that, but also we need to be thinking about, it's not enough to think, are they aspirating? But we also, as Jim Coyle pointed out in 2019, we need to think about the volume that's aspirated. So how much are they aspirating? The contents of that inoculum. So what are they aspirating? Are they aspirating their secretions? Are they aspirating water? Or are they aspirating something much more concerning like medication or stomach contents? And we also need to be thinking about the integrity of the host defence mechanism. So who's aspirating? Are they patients that are fit and healthy and walking around? Or are they patients that are immunocompromised for various reasons? And so those key things are really important to consider when we're risk assessing patients and their swallowing. So, little mythbusters. So when I started working with swallowing patients over 20 years ago, one of the things that I used to hear a lot was that tracheostomies anchored the larynx. It's not true. So just to bust that myth, tracheostomies don't anchor the larynx. There's absolutely no evidence that that happens, but I still, from time to time, hear that spoken in hushed tones. A tracheostomy itself doesn't cause dysphagia, so its removal is unlikely to cure it. So saying to a patient who's dysphagic, it can be better once the trachea's out, isn't a thing and shouldn't ever be a thing. And a tracheostomy does not mean a person needs to be nil by mouth. So it's really important when we're thinking about patients and their swallow that we're thinking about what's the mechanism of injury, why is it that they're struggling, and so that workup, that case note review is really important. We need to be thinking about, is there an injury to the mucosa? Has there been any form of trauma, intubation, malignancy? Or is there any sort of trauma to the chemo or mechanoreceptors? Is there injury to the structure of the larynx, the pharynx, the oropharynx, are there granulomas? Is there prolapse, dislocation? Was there recurrent laryngeal nerve in the surgical field? Is there cancer? Is there trauma? Think about whether there's physiological damage. So has there been extrinsic pressure from an ET tube, which can impact on pharyngeal plexus, hypoglossal nerve, vagus nerve? Think about whether the patient might have a progressive neurological condition or congenital disorder. Is there disruption to the breathe-swallow synchronization? So that's particularly relevant in terms of thinking about comorbidities such as COPD. Think about the pathology. Altered airways are really important to consider. Systemic disease, viruses. Is there weakness or polyneuropathy? So we might be thinking around systemic disease, ITU stays, palliation, disease chemical restraint. Has the patient got poor expectoration? Is there fluctuating consciousness, or is there exacerbation of comorbidities? So one of the assessments that we might carry out is a video fluoroscopy. It's really important that you consider which assessment you might want to use and why you want to use that assessment. It's not enough just to think, patient's got a swallowing problem, I'll send them for fees. You need to really think through why it is that you're ordering that investigation as opposed to another investigation. So with video fluoroscopy, you can explore the total process of swallowing, so including the oral phase right down to the esophageal phase and any stage in between. You can explore palatal function, and you can really observe that. You can carry out it's a quantifiable assessment of base of tongue retraction, which you aren't able to do with fees. You have the ability to assess consistency of epiglottic inversion and retroflexion during swallow. You're able to measure hyoid excursion, anterior movement. You're able to quantify volume of aspiration. You're able to assess and quantify effects of rehabilitation on swallow competence. So we regularly do swallow exercises under fluoroscopy to see what impact they're likely to have. We can also look at compensatory strategies, which I think we'll go into a little bit more detail in a moment, but we can carry out compensatory strategies under video fluoroscopy guidance so that we can explore which are the best compensation strategies to use. We can assess for tracheoesophageal fistula. We carry out insufflation testing for surgical voice restoration patients. We can assess reflux and pouch, and it's non-invasive. Does have limitations. It's obviously there's radiation involved, which is a consideration. I work in head and neck, so many of the patients that I work with have been exposed to significant amounts of radiation, and this is quite a small amount in comparison. You're unable to assess vocal cord function in the same way that you would do, for example, with the fees. You're unable to use in ventilated or unstable patients. It's really troublesome trying to get those sorts of patients like fluoroscopy suite. Seated patients in wheelchairs, tilt-back chairs, etc., can be a real challenge, and that's down to the size of the equipment that we're using, so that can be really troublesome. And we're less able to make short notice bookings, just down to the fact that you need a radiographer and a couple of speech therapists. We're fortunate here that we're speech therapy led. In some centres they are radiologist led, and therefore it's even more difficult to get the right number of people in the room at the right time. So if we compare that to fees, let's talk through the benefits for fees. It's easy to deliver in any circumstance with most patient groups, so we can do it as inpatient, as an outpatient, front bed spaces, etc., etc. Where we go, we can do fees really. We can assess laryngeal and pharyngeal function concurrently. That's really critical in terms of looking at timing, and that ability to look at laryngeal function isn't there with video fluoroscopy, as I've pointed out. We can assess voice and swallow. And as I think we go on to talk about in more detail, you can't think about swallow without also thinking about the voice. They share the same anatomy. You can look at pre and post swallow aspiration. It's more difficult to look at intra-swallow aspiration, and that's because you get the white out, and because if things are as they should be, the epiglottis is over the top, and it's difficult to see that intra-swallow aspiration. It's optimal for secretion management assessment. So even if a patient's nil by mouth and you're looking at their secretions, we can still carry out FEEs in a way that we're not able to do with video fluoroscopy. And it's effective for multiple reassessments. So you're not going to want to re-expose patients to radiation too frequently, but we can carry out FEEs as needed. And also, really beautifully, it's a really good excuse for collaborative practice. We carry out loads of FEEs assessments here alongside ENT. We have a speech therapy-led FEEs clinic. We also have a joint swallow clinic, but we also carry out loads of swallow assessments jointly on the ward, and that gives benefit for joint learning and collaboration. FEEs does have its limitations, so it is dependent on the scoping skill of the individual carrying out FEEs. And that can obviously vary. It's dependent on the patient being tolerant of the procedure, and we would never spray a patient. They should be able to tolerate it without use of spray, because we're interested in sensation. The standardised use of scoring is variable across centres, and subjectivity is scoping and diagnosing alone. So in terms of thinking through some of the key issues alongside FEEs, think through, when you're thinking about carrying out FEEs assessment, think through what's the mechanism of injury and document all of this. What are the symptoms? So what's the patient reporting? Have they got a voice change? Are they dysphagic? Are they aspirating? Are there issues with tracheostomy weaning? We use FEEs really routinely with patients where we're trying to wean them from the tracheostomy. What's causing the symptoms? Are there motor or sensory deficits? Is there fatigue? Is there deconditioning? Respiratory issues? Is positioning a challenge? What's the patient's engagement like? Which phase of the swallow is impacted? And then what can you see? So when you look down, when you're doing a scope, what are you seeing? Are there secretions? If there are, where are the secretions? Is there a small amount of secretions, or are they deeply pooled, either within the vallecula or within piriform fossa? And is that pooling? Are those secretions symmetrical? And also, are the structures symmetrical? Is the patient aspirating? What's their response to that aspiration? And also, can you just see any food debris? The other thing I would add to that is also, can you see any reflux happening and what's going on at the CP? Because if you're seeing active reflux when you're scoping in a patient that's dysphagic, that's quite a concern in terms of, as we spoke about, the contents of the inoculum that's then going to be going down into their lungs. Can they achieve phonation? Can they sustain phonation? Can they achieve that glottic closure? Is there a palsy? Is there praxis? Is there a phonatory gap? Please do comment on whether there's adduction, abduction, what's the airway like, what compensatory techniques are they using? So, for example, if they're trying to achieve voice, are they using anterior to posterior constriction in order to achieve that voice? Say what you see. That's really useful for us as speech therapists. And if we're not with you, we will always go back to your noting and see what you've documented. So the more information we have about those sorts of things, the better for us. So what makes a good FEEs? That collaboration again. Describe the nasal cavity, the nasopharynx, the oropharynx, the supraglottis, the larynx in order and objectively. Note tonicity and note that kind of symmetry in terms of the tone, note symmetry in general within the structures and their general appearance. Please always comment on the position of the vocal cord. we will always be thinking about, well, is it in the paranesian position? Where is the cord? So you say it's not working, but where is it sitting? Also think about if they have got vocal palsy, what does that mean in terms of the arytenoid? Is the arytenoid prolapse? All of that's really relevant when we're thinking about the airway. And then think about function, comment on phonation, clearance of secretions, compensatory techniques, and create a hypothesis for what that mechanism of injury might be. And then what happens if you put pressure on that system? If you start trialing fluids, if you start trialing diet with the camera down, what happens? Is there aspiration, and is that are the patient sensate to it? And if they are sensate to it and coughing, how well are they then able to clear that from the laryngeal vestibule? Or does it hang around still in that area? Are they unable to clear it? Or is the aspiration silent? So we've done an excellent video fluoroscopy, or we've done an excellent really well, but now what are we going to do about it? So now we need to rehab that patient. We need to rehab them so we can get the trachea out. We need to rehab them so that they can voice. We need to rehab them so that they can swallow. So when we're thinking about rehabilitation, we think about compensatory strategies versus improvement in function. And it may be that we need to employ both techniques. So in rehabilitation, we're using exercise to improve function. So that might mean increasing the load, or increasing the frequency, or increasing the resistance that they're utilising. And that might just be with a bolus. So we might go from fluids to yogurt, for example. And in doing so, we're increasing the resistance. And then going from a half teaspoon to a full teaspoon, we're then increasing the load. So it's not just, when we write our recommendations, we're not just thinking, oh, great, we've got them from this to this. Actually, we might be using that very much as part of their rehabilitation. And then in terms of compensation, we might be thinking about postural changes. You may well have seen things like a head turn, for example. If a patient's got a vocal palsy, we would advocate turning the head to the side that's affected. Or in the case of weakness, we might be suggesting, so pharyngeal weakness, tongue weakness, we might be suggesting to tilt the head to the stronger side, for example. We might advocate other things like a chin tuck. I think I increasingly do that less and less. And I tend to only do it when I've used instrumental assessment to demonstrate that that's helpful. But there are a variety of head postures that we might employ, but it needs to be based on good assessment, not just, I saw that in a nursing home once, thought that was a good idea. We might advocate eating adaptations and manoeuvres. We might also advocate bolus modifications, so thickening fluids. We don't tend to use that very much here in this institution. We will use it when necessary, but I can probably think on probably two hands the patients that I've recommended thickener for this year. And I work in the swallow clinic, in the Bees clinic, and in video fluoroscopy clinic. So it's not something we use loads. We use it as a rehab tool. I think if we're thinking that, for example, a young patient with MS and you're putting them on thickener, actually the implications of that are really significant. So we use that rehab tool. We really think carefully about whether it's a long-term strategy for patients. But we may well advocate changing consistency. So we may advocate moving from a normal diet to, for example, normal diet but with softer options diet, puree diet, single textures, or fluids only. But again, where we're doing that, we would be doing everything we could to get them back to managing a much more normal diet. Because I think, as we all know, you want to be able to eat some birthday cake. You want to be able to have a glass of wine. You want to be able to attack that buffet. And so it's really important that we don't just go with the status quo, but at all times we're trying to think about how we can compensate and how we can rehabilitate to improve function. And sometimes we have to advocate for a short-term use of nasogastric tube to improve chest status, because if you've got a chest that's going off and a swallow that's not great, those two things are going to play into each other. And so actually sometimes just giving everything a bit of a break, utilising short-term nasogastric tubes, then be able to get going again is really important. We would, as much as possible, advocate for sips of water during that time if a patient can tolerate it, even ice chips, teaspoons of water, anything just to maintain that swallow function, because we know apnea is we know that, my word's gone, and when we don't use it, we lose it. We know it's not great. So we would suggest continuing to swallow as much as possible, even if patients have to be nil by mouth. We're going to be reducing risks of choking, so thinking about positioning. That can be really challenging in certain populations, such as learning disabilities, etc. So thinking that through is really important, and thinking through what patients do at home. It's all well and good us assessing them in a bed in the hospital, but actually if patients are going to go home and be on a recliner on the floor, actually we need to be thinking about referring to our community colleagues so that appropriate assessment can be done there rather than in a strange environment, for example. We need to ensure that there's good oral care going on. We know that if you aspirate in the presence of really dodgy oral secretions, then actually your chances of developing a raging pneumonia are much increased. So really good oral care is imperative. And we also need to be engaging patients and families with the science and understanding of dysphagia. We don't do this because we like a chat and we think, let's have a chat, see you swallow something and put your head in that way. We need to really engage patients with the science of what we do. These are the sorts of things that we would be documenting on a FEES examination. So I'm not going to go through all of those in great detail. I think hopefully all of those are fairly self-explanatory, but it's useful sometimes to have a bit of a pro forma that you're thinking through, just to kind of prompt you to think, oh, actually, what did the epiglottis do? Was it rigid? Was it moving? Was it edematous, etc.? And actually, edema is something that really impacts on swallow function. So if you've got a patient coming to see you that walks in with that kind of gravelly, deep voice after radiotherapy, then you are going to be thinking, you're still sounding really edematous. Before I've even put my camera down, I can hear that you're really edematous. And because I can hear you're really edematous, I'm already thinking, what's your swallow function going to be like? And Joe Patterson, who's a professor at Liverpool University, has developed Patterson edema scale, which Heather Starmer from Stanford has been developing further, which is a really lovely structured way to assess all of the structures for edema. So it gives a 4-point scale, and we utilise that loads here. We utilised it a lot during COVID when everybody was being extubated and were very edematous, and we utilise it loads in head and neck. So takeaway points from a FEES perspective: use deliberate and sound principles of workup. Think about systems that are working. Are they working in synergy or in competition? Actually, patients' number one priority is to breathe. If breathing is too much if breathing is too compromised, they are not also going to be able to swallow. Listen and observe. So thinking about if a patient sounds stenotic, then probably their swallow is going to appear stenotic. So don't think that just what you're hearing, you're not also going to see when you look at their swallow. Ask the patient how they're eating and drinking. Dig deeper. So if you're hearing something, start to dig deeper. And ask that question: what happens when you swallow? What are you managing? What did you have for breakfast? It's amazing how many times you say to a patient, how's your swallow? And they go, yeah, okay. And then you say to them, what did you have for breakfast? Well, actually, I couldn't manage anything. What did you have for dinner yesterday? Oh, actually, yeah, I managed a bit of soup. And then as you start to probe, you realise that actually this patient's really dysphagic, but it's just become quite normal for them. And deliberately choose what imaging approaches you want to use based on what you know about those assessments, the benefits, the pros, the cons. Document in a standardised way and work collaboratively. So we're now going to move on to thinking about laryngectomy swallows. We do loads of work here on laryngectomy swallows. We do loads of assessment here. I was in VF clinic this morning. and was troubleshooting with a lady who's having some issues with her valve. The first thing we think when we think about things that are changing is we need to take this patient to videography and see what's going on. So as you can see here, this is what the swallow looks like after laryngectomy. So we've just got some stills, and I think in a moment we've got a videography as well. So as you can see here, the patient's got a pseudoepiglottis. Hopefully we're not seeing too many of those, but I think we do still see them in some people's practice. So here we're quite fortunate in that we take a lot of tertiary referrals for problem solving. So we do get to see interesting things. We can see the reconstructed segment, and then the patients, then the bolus is then kind of split. So you can see we get quite a lot of residue within the oral cavity, between the base of tongue and posterior pharyngeal wall, just sitting above that pseudoepiglottis within the reconstructed segment itself and within the esophagus. And then that's post-swallow. You can see that there's still a small amount of residue, a small amount of coating within the reconstructed segment. We often think about how much the neopharynx and the esophagus are dilating, because we know that stricture can become a real problem for some patients. So we need to be thinking about how much they're dilating, what is the optimal dilation. We also think about the oral phase. We don't just think about what's going on in the throat with a laryngectomy patient, we take it right back to what's going on with the oral phase. So with the oral phase, we're thinking about the lip seal. It's healthy, have they got healthy, well-fitting dentures? Their soft palate competence? Is there adequate tongue movement? So think about what the hypoglossal's doing, what surgical intervention they've had. Have they got trismus? Is there previous CRT? Have they got fibrosis, xerostomia? And lubrication remains a real issue for patients who are post-CRT. Are they in pain? Have they got a loss of appetite? So moving on to think about the pharyngeal phase. So this patient, I don't know this patient, but looking at that, they've got a huge amount of lymphedema post CRT. And that can lead to real issues in the early days around, because the edema is so extensive, they'll struggle to get things down. But as that settles, that will lead to fibrosis and stricture and stenosis. This patient's got inadequate intraoral pressure, inadequate base of tongue to posterior pharyngeal wall approximation, reduced stripping action in the pharynx to support the bolus propulsion. And we think about that stripping wave a lot. And as this says here, there's diffuse effect of the lymphedema, and it's really extensive, that lymphedema. We need to be thinking about the chronic pharyngeus and the upper esophageal sphincter when we're thinking about function post laryngectomy. All patients undergoing a total laryngectomy should have a myotomy. That's not something that you should ever compromise on. They should all get a myotomy. Otherwise, they will develop issues around voicing. So spasm is much, much more common in patients that have had an incomplete or an absent myotomy, but also dysphagia as well. So yeah, you can see that supraepiglottis there. So this occurs when the suprahyoids aren't retrieved from under the chin and then resutured to the reconstructed thyropharyngeus. So that's the second layer of the pharyngeal closure. And then pressure within the neopharynx due to the base of tongue to posterior pharyngeal wall movement gradually stretches that mucosal lining at the tongue base, which then creates a pouch. And it's that pouch that gives it the appearance of a pseudovallecula. And then the bolus can collect and remain post-swallow in that pseudovallecula. So here you can see another example of a pseudoepiglottis, and here that's now forming a bit of a dam to prevent bolus propulsion. So there, I would say that's even up to, it's definitely 2/3, even up to 75% of the lumen being impacted there by that pseudoepiglottis. So that's really significant. And you can imagine as soon as you go into much more normal diet textures, the challenges that will present itself. And just at bedside, you'd be expecting that patient to be doing multiple swallows, multiple effortful swallows. So this is slightly different. Here you can see those hypertonic tissues at the posterior pharyngeal wall. And that's potentially caused by non-reconstructed cricopharyngeus and thyropharyngeus muscles. I think actually that's probably much more likely to be the thyropharyngeus. And that presents as a dynamic protrusion. So it's a smooth protrusion and it's dynamic, so it moves on the swallow. But it can abut the anterior wall on voicing attempts, although what impact that has on the voice is debatable. And it's not always an issue on swallow, but it's certainly something that we see regularly. So fibrosis and stricture, again, is a common picture that we see in patients, swallows who've had a laryngectomy. This can be caused by surgery and or chemoradiotherapy. It can occur at one single point or along a whole length or even along multiple points. It behaves the same on the swallow and voice. So unlike spasm, which is dynamic, you would expect to see fibrosis and stricture to behave the same way on both swallowing and voicing. And when we take patients for videothoroscopy who've had a laryngectomy, we're also looking at their voicing. And it can cause moderate to severe dysphagia. And it can have a varying effect on voice, and depending on how the walls and vibratory segment vibrate. But again, thinking about your clinic rooms, if you're having laryngectomy patients come to see you for follow-up, if their voices are changing, if they're becoming more whispered, if they're becoming sort of tighter sounding, breathier, those might all indicate to you that actually there's some fibrosis going on. And then that might prompt you to say, how's your swallow? Are you managing, what did you eat last night? Are you managing to get down your dinner? Are you having to take an hour to get it down? And then at that point, patients might say to you, actually, it is taking me longer. So at that point, you are want to do videothoroscopy or barium swallow. And then patients might also experience some aerophagia if they've got a valve, because as more air enters the esophagus, then can leave by the vibratory segment, then patients are more likely to get aerophagia and air entering the esophagus and going down into the stomach. One way you can overcome that is to reduce the lumen size of the valve. So if you're in a 20 French, you might want to take them down to 16 French if they're reporting aerophagia. The other option is a dilatation. So here you can see two images of the same patient. It's really, so we would always advocate when we're doing videothoroscopy, we would always advocate doing lateral views, A to P views and oblique views, because we don't think you can get all the information unless you do all three. And you need to be looking at liquids as well as diet. So for example, you can see the patient here, thin liquids are passing with relative ease. But as soon as you head to diet, and it's like a rice pudding, there's photostasis, and that's due to xerostomia and paralysis of the pharyngeal musculature. So it's really important to do both. If you don't have ready access to videothoroscopy, it might be worth thinking about a barium swallow, but requesting barium swallow with diet as well. What is the stricture? So you can get oncological strictures, and we've certainly, as you can see there on the left, and we've certainly had a number of patients that have presented with stricture. We've taken to videothoroscopy, and it's become very evident during that procedure that actually this is about recurrence or immune primary rather than benign post-CRT changes. So this slide demonstrates that you can have stricture at a number of points. So you can see there the stricture in the neopharynx. You can see the pooled bolus beyond, which then sits above the next stricture, which is the stricture of the reconstructed segment. And that bit there, that pipe you can see coming out is a Foley catheter, which is sitting there through the TOP. So we're getting there. So if we're thinking about surgical voice restoration, let's think about the things we can do to optimise outcomes. So breath support's really key. Actually, it's not enough just to, so it's really key in terms of how the patient is preoperatively. If you've got a patient that's got really bad COPD, you might well think they're not a candidate for the surgical voice restoration. The other thing, though, is also thinking about technique. We spend a lot of time after a patient's had a puncture, either as a primary or a secondary procedure. We spend a lot of time just teaching technique. It's not enough just to think, right, you've got a valve, crack on. Actually, how do they use that in everyday life? We need to be providing therapy for that. And that's why it's really important that they see a speech and language therapist both before, during their post-operative stay and then outpatients. The valve selection is really important, choosing the right valve for the right patient, ensuring they've got adequate airflow through the valve and airflow through the upper esophagus and the neopharynx. Voicing technique is really important, as I've alluded to. Then there's surgical considerations. So what kind of reconstruction have they had? Are they just a straightforward total laryngectomy? I don't know that they really exist anymore. I think from the data that we did recently, less than 6 of our patients are just total laryngectomies. The vast majority will have flat reconstruction of some form or another, and that obviously has an impact on voicing and what we'd expect from voicing. And then think about the vibratory segment. Where is the vibratory segment? So in a straightforward total laryngectomy, we'd expect the vibratory segment to be the PE segment, or the cricopharyngeus, but it may be within the jejunum, it may be within the ALT flap, for example. For a stomach pull-up, you're much more likely to see that the vibratory segment is the lower anastomosis. And so video fluoroscopy will be able to show us exactly where the vibratory segment is. Let's remind ourselves how a voice prosthesis works. So a voice prosthesis shunts air from the trachea into the esophagus, and when the patient occludes the stoma, so once air is in the esophagus, it vibrates the cricopharyngeal segment to produce voice. So the valve's a one-way valve, so it opens to allow air into the trachea, but it remains closed to prevent food or liquid from passing into the airway. So it prevents aspiration. So the sound source is the vibration of the cricopharyngeal muscles. So this is a picture of an open TOP, esophageal puncture. So you can see there on that posterior tracheal wall, you've got that puncture just there. And then that's a voice prosthesis in situ. Some voice prosthesis facts. So we used to think that a valve needed changing about every 3 to 6 months. Actually, in recent years, there's been quite a lot of work done by MD Anderson, and they found, I think they looked at over 1,000 patients, and actually their average was about 63 days. So actually, if a patient's doing a couple of months in a voice prosthesis, that's probably okay. There are obviously things that we can do to increase the valve life. So there are a number of things that impact on function, and success is an individual thing. But one of the key reasons for valve failure is the biofilms, so the candida and bacterial colonisation that live on the valve, gastroesophageal reflux, and that interplay between the acidic conditions and the biofilm. Candida loves acidic to heart conditions. And then how granulation tissue emerges and transforms, and the impact of the biofilm on that. And then there's pressure-related swallowing or breathing issues can impact on the valve and the kind of valve selection that you want to make. Size changes, the diameter of the length, and failure results in liquids leaking through and therefore aspiration. It's a bit more gentle to say they've got a leak. It's actually a bit kind of scarier really to think actually what we're seeing is that aspiration. So just a couple of slides just to finish. We're just going to be thinking about how you manage a dislodged valve. What I would say is you need to manage it in the way that is done at your centre. So you will have a protocol at your centre, and it's important to do what you would do there. We've just outlined here what we do at our centre. So a patient may cough the valve out or accidentally pull the valve out. Here, we wouldn't want you then putting that same valve back in again. It's come out for a reason. Either the patient's unwell, they've got something going on, which means their tissues aren't retaining, or maybe the valve's now too short. Maybe they've put on weight, maybe they've got some edema, which means the valve's become too short. So actually, when a valve's come out, we would always want the valve to be resized. So at 3 o'clock in the morning in A&E, you're not going to want to be doing that. So we would suggest just putting a Foley catheter in. And you also want to identify where the valve is. So patients might say, I think it's at home, I think it's right under the settee. Actually, if you don't know where the valve is, if you haven't seen the valve, you do need to think about how you can identify where the valve is. So are you going to scope them, or are you going to send them for a chest x-ray? If you can't find it, you can think about a CT scan. And that's something that Margaret Coffey is advocating at Imperial. She's done some work around a protocol for that. So obviously if the tract's open, patients are going to aspirate, so that's really important to get something in place. Here we use Foley. You might not do so in your centre because people may have concerns around that. So we use it because we think it's the best thing to use. It allows you to retain the TOP, so it prevents it from closing over, and it also prevents aspiration. If you can't get a Foley in, then you might want to see if you can get a paediatric NG tube through. That's sometimes quite a good way to save the tract. It's certainly what we do here. If it won't go in easily, if it's not leaking and the patient's not voicing when they cover over, that tract's probably gone. And you don't want to really be trying to force a Foley through or force a paediatric NG tube through, because you're going to create a split party wall. So a split party wall or a false tract. So if it's gone, it's gone, and then the patient would just have to be re-punctured. So you can look for central leak with blue dye in water, or a brightly coloured drink, or milk, but actually it's better to go for slightly watered down milk, because milk's a bit thick and doesn't always leak through. So if patient's leaking through the middle of the valve, so this patient's got a valve in, but they're saying that they're leaking, try cleaning the valve, use their brush, try and blast through, so get them to cover over their stoma and do a big huff, get them to sip water, clean through again, huff through again, and sometimes that's enough to get things sorted. If the leak's minimal, then they might get away with thickened fluids until they can get their valve changed, and normal diets. If it's really significant, they might have a plug if it's an indwelling valve, so either like a Vega or a Classic. They may have a plug that you can utilise. But if the leak's really significant and they don't have a plug and they're not appropriate for that, then you may even have to think about removing the valve and popping the Foley catheter in. This is a dilator. I wouldn't necessarily advocate for popping the dilator in place. I think probably a Foley catheter is better, because this obviously dilates the tract up slightly more, but if that's all you've got to hand, it's an option. This shows Foley catheter in place in the TOP, and that is a really enlarged TOP, which, so you can see those tissues aren't beautifully hugging the Foley catheter. So that's going to lead to peripheral leak. So when we think about what's causing the leakage around the valve, the most significant reason why patients leak around the outside of the valve is that the valve's too long. So check the size of the valve, check whether the valve's too long. It may just be that they need to be downsized. Also think about what was the size of the initial puncture. So if you're puncturing at like a 22.5, where have you got to go from there? So we would really advocate puncturing small. So your first valve, thinking about a 16 or 17 French valve, not going straight to the 22.5s, because you can always go up. It's really difficult to go down. Has the patient had previous radiotherapy, particularly chemoradiotherapy? Is there recurrence? And that's certainly something we see in our population here. If patients have got recurrent disease, they are much more likely to present with peripheral leakage. And equally, if there's something systemic going on, like hypothyroidism, diabetes, rheumatoid arthritis, all of those things are likely to mean that patients are much more likely to leak around the outside. If they're malnourished, if they have a stricture, if they smoke, if they're on steroids, all of those things are things to think about. Also think about the type of valve that they're in. So If a patient's, for example, in an X-dwelling valve with a small flange, do you need to think about putting them into an indwelling valve? If they're an indwelling valve, it's the correct size. Or if it's just slightly long, think about whether you need to go into a special length valve. So we know that they come in 2 millimetre increments. Actually, you can get them in 1 millimetre increments with a specialist valve. Or do you need to be thinking about heading down using a large esophageal flange or a large esophageal and large tracheal flanges? Think about whether there's an acute infection there, and also think about whether the patient has this as a primary or a secondary procedure. So just a few things briefly to think about. Again, check where the leak's coming from. If it is leaking around the outside, try off some thickener. And they can probably go home if it's leaking minimally. If it's really significant, you might have to admit them for an NG tube. That may well be enough to manage it. If it's really significant and you're dealing with a really enlarged tracheoesophageal puncture, you may have to think about utilising a tracheostomy tube. But I don't know what your experience is, but ours here is definitely that patients really poorly tolerate tracheostomy tubes, particularly patients that had their laryngectomy many years ago are really poorly tolerant of a tracheostomy tube. They find them really uncomfortable. And just lastly, to finish, this is a patient who underwent supracricoid partial laryngectomy. So for those of you that aren't familiar with that procedure, that's where the vocal cords, the false cords, both paraglottic spaces are removed, and you're left with one functioning cricoarytenoid movement or complex, or ideally 2. And ideally an epiglottis as well. So in what you're about to see and hear, hopefully, is that this patient is able to, with really intensive therapy, and these are the patients that we would see 3 times a day in their post-operative phase and really frequently as an outpatient, but with really good surgery, really good speech therapy, and the right patient who's willing to really put the work in, you can really achieve amazing things through rehab. So what you will see is I will play it. I'll let you listen to his voice.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So this gentleman, I don't think if you met him, if you saw him in your clinic room, I don't think listening to him that you would realise, I certainly wouldn't, that he didn't have vocal cords. So he had a heck of a lot of speech therapy. And what you're noticing as you're watching it is that his arytenoids are tilting forward, his epiglottis tilting back, and he's got a beautiful way
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22.
And that's acting like a sphincter, and that's really important if we were to then go on to talk about the swallow function after that procedure, but that's for another day. Okay, and so I've gone. Right, okay. So, yes, that was Camilla's presentation. So, any questions, direct them to her. No, I'm happy to take questions.
Wow, Jo, that was an absolute tour de force. Thank you.
You're welcome. Thank you. Are there any questions? Don't make them too difficult.
I'm sure Emma will start off with some questions. For anyone who has questions, we'd welcome you to put them into the chat, please. Thank you.
I'm just going to stop recording. So for those catching up online, please make sure that you join in person, as we're about to talk about the things that you can't record.